Hi, everybody, and welcome to the Kidney Coach YouTube channel. I am naturopath Fiona Chin, co-founder of Kidney Coach, Kidney Disease Solution, Kaigenesis, and all things related. And I have the pleasure of being joined again today by the beautiful, amazing Lindsey Zirker. She is a renal dietitian from Kidney Nutritional Institute. Lindsey has a special interest in all things autoimmune disease and related to kidney disease, and she's got a brain that I'm always grateful for because she asks the bigger questions and really thinks outside the mold of the box. So whenever we get together, we have a really good chat like we were just before I hit record. And Lindsey's been furthering her education into all things minerals and the biochemical pathways and the way that minerals interact with everything in the body. And we had a chat. We're like, we really need to have a discussion about this because it really isn't zinc is low, let's treat that, or calcium's low, let's treat that, especially when it comes to kidney disease and just the interrelationship that minerals have with all the other functions in our body. So, Lindsey, I'm going to hand it over to you. Thank you for joining me. Thank you for your amazing brain and everything that you are going to bring to this podcast. I know it's going to be fabulous.
Thanks, Fiona. I'm always excited to share the fun new things that I learned because I think I learn also really well by teaching and
Yeah.
sharing. And I think that whether you're a patient or a provider, it really helps to just be reminded of some things or get a new perspective on some of the things we've heard a lot about. And I think that with kidney disease, so much of the focus of the renal diet historically has been on minerals. And so a
Mm,
lot of times people are kind of like, oh, what more are we going to talk about here? And
yeah.
so that's some of the things that I learned in doing a deep dive into minerals recently is what I wanted to share with you guys today. And hopefully it helps you in some way.
Sounds
Um,
amazing. Deep dive away, my friend. Deep dive
yeah.
away.
So one of the big aha things for me this last time is the interplay between minerals and hormones.
Mm,
Definitely, we hear a lot about like calcium and parathyroid hormone and how they are so closely working together to help with bone health. But the thing that I think that we forget about with minerals is like we're in kidney disease, we're frequently checking the serum levels of calcium and phosphorus and potassium and sodium and iron and these things. But the serum levels, they don't really tell us very much of the picture because the serum levels are so tightly controlled by hormones. And so a lot of times we've been reacting with the serum like, oh, someone's calcium is high. We need to reduce the calcium in their diet, or someone's phosphorus is high. We need to reduce the calcium in their diet. And especially for people who have earlier stages of kidney disease, there's really more appropriate, better recommendations. Um, and even for people who say, are on dialysis, remembering that if serum levels of minerals are off or strange, it's really telling us that the hormones are not
yeah.
well balanced. That something is going on with the hormones. And so we can look upstream from there and say, well, okay, what's going on with those hormones and address it from that perspective. And we're
Mhm.
likely to get more effective interventions for our patients.
Give me some examples of that, of when, you would go, okay, well, this is a hormone related issue versus maybe a straight mineral deficiency that's coming up in the serum.
Yeah, one of my favorite ones that actually has been coming up a ton lately is potassium and sodium balance.
Mm,
I've been seeing a fair amount of my clients who, maybe stage 5, late stage 4, and they've got, moderate high potassium levels, like, 5.4 to 5.6, and then kind of lower sodium levels. And of course, they're getting conflicting information, and their blood pressures have kind of been bottoming out. And so it caused me to take a deeper look in like what's controlling these. And we hear a lot about the renin angiotensin feedback system. And a lot of times it's easy to forget that, the different blood pressure medications, they're specifically working on different hormones in that system.
Mhm.
And one of the common ones, like lisinopril, it suppresses aldosterone levels. And that causes a lot of what kind of I've been describing is those moderately high potassiums and those really low sodiums, and then kind of their blood pressure bottoming out. And no one's thinking about, well, it's this blood pressure is further pressing down their aldosterone too low, and they keep trying to make adjustments with their diet, but they're not successful, especially with the potassium. Like, they're usually way under eating on potassium for that. And so that's a really good example of, like, let's consider a medication change. Let's consider, what hormone pathways are being affected here rather than adjusting the diet.
It's fascinating, isn't it? Because I know Jess and I have spoken about this at nauseum, just about potassium. And you
Yeah.
know how much it gets a bad rap. And I know you're in the same boat as us, which is like everyone takes out potassium and kidney disease. And then when we know that heart disease and high blood pressure is the leading cause of kidney disease, and then we go, well, we're going to have probably 90% of our patients on blood pressure medication, probably affecting the renin-angiotensin system there. And
Mhm.
potentially it's the medication pushing out the potassium, nothing to do with the kidneys pushing through potassium, which is the story that we get, and then we have to reduce it. And then, as we know, you take potassium out, you actually increase the risk of cardiovascular disease, of accelerating. The studies now show that it accelerates further kidney disease if you take it out. So it's really fascinating when you put all of that together and you go, well, potentially as practitioners in general, we're making these huge mistakes where we are taking out potassium and maybe further increasing the risk of heart disease or cardiovascular disease. We know potassium is so important to regulate
Mhm.
heartbeat and all of those sort of things, versus looking at the role that the hormones and all of that is playing upstream. So it's a really, really, really good example. So in that example, are there specific, you said obviously you've got slightly decreased sodium, maybe slightly. It's not, doesn't sound like it's blowing out of the reference range. It's just this tweaked sort of potassium level that, again, people may flag about. When it comes to practitioners or people looking at their own blood work, what would you recommend when they see that, slightly decreased sodium to potassium sort of ratio? Um, what do they do about that? Is it finding a good practitioner? How do you then get your minerals to work properly? What's the follow through there?
Yeah. I'm still kind of working through that to a degree. But I think it definitely starts with having a conversation with your provider.
Mm.
Um, like, a lot of my clients are tracking their intake, and so they can go in and be like, hey, I'm eating, less or around 2000 milligrams of potassium a day. And I mean, the research shows that even that is too low of an intake and
Yeah.
increase your risk for AFib and stuff like that. And so just saying that, and then just saying, hey, can we consider a different blood pressure medication? Also, with these patients, their blood pressure tends to run a little bit more low when that aldosterone is really low.
Okay.
And so I mean, it should be signaling, you know, hey, we need to do something different. This isn't quite working here, but it doesn't, it's easy to overlook. And so I think starting the conversation with the doctor, I have had clients get off the medication, but even 2 or 3 months later, we're still seeing that really low sodium and higher potassium level.
Oh,
And
fascinating.
right. Um,
Mm.
so I've been also double checking with my clients uh, that they're not taking any nitric oxide supplements because that tends to further suppress aldosterone
Mm.
levels. And which is kind of weird because a lot of times we hear so much about kidney disease being a nitric oxide
Mm.
deficient state and that contributing to these different issues. But for those who are either on those blood pressure medications that reduce aldosterone levels, or for whatever reason they just have lower aldosterone levels, then you know, not using nitric oxide is probably a better option for them. And I just think that there needs to be an increased awareness in the nephrology community about this because I
Mm.
just keep running into it the past few months with my patients, and maybe having an endocrinologist work with them and find out, why is their aldosterone so low? Why is it not coming back up after we stop the medication? And then, they can hopefully help with that. Beyond that, I haven't figured out like lots of solid solutions yet. I don't know if it's something you've run into and you found some good support for that.
Well, the only thing, and Jess and I did a podcast on this too, was that when you see that renin-angiotensin system doing that and the aldosterone and the potassium being slightly up, that sometimes when you supplement magnesium, the potassium will come back into
Mhm,
range, like it can be a magnesium deficiency.
mhm,
And especially if their blood pressure runs a bit low, it's interesting because people think not to use magnesium because obviously being a vasodilator, but
sure.
uh, I found magnesium citrate for whatever reason, and maybe just checking that they've got some sodium in their diet too, because that's the other issue, right? Like everyone gets scared of salt.
Mhm,
We do
mhm,
know salt will bump blood pressure in a certain amount of individuals with certain genetic
right.
predispositions to it, but making sure that like good quality sea salt and magnesium are in there because obviously potassium, magnesium, and sodium all sort of work around with intracellular cellular balances and things like that. So back to your original point where we have to think about minerals outside of isolation. If we've got a potassium issue, I sometimes do think what's magnesium up to and checking that. But, serum magnesium tells us nothing. And even a red blood cell magnesium doesn't tell us much because there's not a lot of magnesium sitting in those tissues. It's embedded in tissues. So when you start to get a decline even in red blood cells, like magnesium is already like way too low. So
Mm.
yeah, that's the only other thing that I've sometimes seen is you put some magnesium in and a little bit of salt, and that sometimes can fix it, but probably not for everyone. And you're seeing it sounds like you're seeing a lot more than I do. So
Yeah, so I've just been encouraging them to, like, ask to get their aldosterone levels checked.
mm,
Although I find it interesting, the reference ranges on the labs that I'm seeing, like, the normal range, of course, it depends on age and gender, is between
yeah.
0 and, like,
Mhm.
33, and I'm like, "How is it normal for a hormone to be at 0?"
I know. It's a
So
very busy
weird.
reference range. And then, of course, you've got to go back into like if our aldosterone's out, what's the pregnenolone steel pathway doing? Then we're starting to look at cortisol. And then, we're starting to and this is the thing, right? It's like it's unwinding a ball of thread and why I
Right.
think working with qualified nutritionists and naturopaths. And I mean, this is information that your nephrologist just won't have because they've done no study in this. Okay, so that was the potassium link. What about you were talking about iron as well? That also has a
Yeah.
really fascinating link. And of course, in kidney disease, we see so many people on EPO injections, low hemoglobin, low iron. So tell me about that mineral and what you've been finding in clinic when you've done this deeper dive.
Yeah. So definitely, especially in my CKD not on dialysis patients, I see a lot of neglect in treating their anemia, especially if they're in that above 10 but below 13 range. And I feel like it's weird because there have never been any studies that show that people with kidney disease feel okay when their hemoglobin is in that range, as opposed to normal people who feel like trash when it's in that range, right?
Mhm. Yeah.
Um, and so I'm always looking for ways outside of the EPO to support patients just because as a dietitian, I can't, prescribe that and stuff. And so, everyone talks about inflammation playing a role and like
Mhm.
folate and, iron and all these things playing a role. And so again, thinking about how hormones control minerals, hepcidin is something that I just feel like doesn't get talked about very much, but hepcidin is super control freak when it comes to iron absorption and releasing iron out of storage. And in people who don't have high levels of inflammation with chronic disease, when iron levels drop, then hepcidin levels also drop, which means the body can absorb more iron and it will release iron into the blood circulation, allowing the body to put it into more red blood cells and things like that. But when someone is super inflamed or has chronic disease, like kidney disease, hepcidin levels tend to run really high. And that means even if someone's getting that iron, they're not going to absorb it. And then it's just going to stay in that storage form. And I think, again, we've just gotten really comfortable with our CKD patients having these crazy high ferritins. and just being like, well, they have inflammation. What can we do about that? But I
Mhm.
think, if we look at that, we're like, oh yeah, like our oral iron is 0% effective here. And so we can stop having patients be taking iron sulfate, causing all these GI issues and stuff like that, and just say, let's work on inflammation. Is IV iron appropriate for this patient? And as we reduce that inflammation, then those ferritin levels, can actually be used and released into the circulation and really help prevent those iron deficiency anemias our patients are dealing with.
Yeah, fascinating. So in that blood work, you'd definitely be looking at hemoglobin levels, you'd be looking at ferritin levels, and then really putting it together with that picture of elevated ferritin, maybe
Mhm.
an ESR or a high sensitive C-reactive protein, seeing if it's a inflammatory issue. Can you measure hepcidin? I don't know if that's one I've ever come across in a test.
Yeah, I actually did look into it, and like many hormones, it's very difficult to get an accurate measure. I feel like, we know that like with parathyroid hormone, like it's always intact parathyroid hormone, and we know that it's a bit shifty to measure. And hepcidin is also the same. I know that I actually looked at Brigham Young University was developing some new, less expensive, more specific methods of testing hepcidin. But when I looked it up on different labs like Quest and LabCorp and stuff like that, I wasn't finding any hepcidin
Mm.
assays to draw. And so it's a little bit of a process of elimination, which you really have to do anyways with anemia because so many things can contribute to that. So like you can look at and say, okay, iron deficiency if the mean corpuscular value is kind of low, because you have those smaller red blood cells, and
Mhm.
then ferritin levels are going to be high, and you can be looking at B12 levels and folate levels and making sure that those seem like they're in a good range. And um, a lot of people think about like looking at CRP to see if there's inflammation, but CRP is really only showing you inflammation from certain pathways. It's not. I've had plenty of people that I know are really inflamed and their CRP looks fantastic,
Yeah, totally. I'm the
right?
same. Unless you're doing a full cytokine panel, which
Yeah.
you need interleukin 6 and
Yeah.
all of those, interleukin 10 and all those guys as well. But yeah, no, I agree. I often, especially in my autoimmune patients, their HSCRP and ESR can be completely normal. And then you run a cytokine panel and you're like, yeah, no, you are so inflamed,
Yeah.
but see it otherwise.
Yeah, I feel like the ferritin is a really helpful one, and especially, as with any labs, because we know there's shortcomings with all of them, looking at the trends. And so if you're seeing like, hey, we're seeing this trend of like this ferritin is staying high, and all these other levels are like the TSAT and total iron binding capacity, those levels are low, then we can say, okay, let's identify some inflammatory pathways that are active here and work on those. And then hopefully we can start seeing a trend of those ferritin levels dropping. And then we can know that we're being effective. And then hopefully you should be able to see an improvement with total iron binding capacity and the TSAT and all that as well.
Would you say inflammation plays a role in mineral imbalances more than just in iron? Have you seen it disrupt other mineral states?
Yeah, I think it can because looking at the different cofactors that other minerals are involved with, like zinc, for example, such a huge role in immune balance. And so, of course, if you're inflamed, the immune system is using different resources to put out those fires. And also, like in the gut, helping that gut lining be healthy and strong and healing that. And if you continually have assaults on that gut lining from inflammation or pathogens and stuff like that, you're going to see a drain on those resources. So, um, definitely. And then also like magnesium playing such a role in alkalining and inflammation, creating more acidic environment. So definitely inflammation can play a role with multiple mineral balances for sure.
Yeah, that makes sense. And what other gems like did you come out of your extra deep dive and go, oh wow, like I hadn't considered that, or that's something I really, need to make sure I'm aware of going forward with patients? Were there some other major standouts in there?
Yeah, one of the things that I thought was so interesting, I was really worried when I came to the part in the course of talking about phosphorus because I feel like we talk about phosphorus so much, like what else is left for us to say? And so I was just like, oh, I don't want to say the same old boring stuff. But as I did the deep dive into it, um, there was a couple things that were really interesting to me. One was that the biggest predictor for good serum phosphorus was residual renal function. And so I thought that makes me think, especially for our end stage patients, the ones that are on dialysis too, like so much more of a reason if peritoneal dialysis, works for them because that does preserve renal function, they're going to have such a better chance at having better phosphorus levels. Um,
Fascinating.
and then, like, looking at nocturnal dialysis or home hemo because you're able to do dialysis longer and more frequently, people also have a lot better um, phosphorus control that way. And I just feel like those are not super well utilized or considered in when we have people that have a really hard time getting that phosphorus in range. And so those aren't dietary, but when we have these, we as dietitians, we're on those interdisciplinary team meetings that, we can say we've checked the boxes for dietary counseling. We've tried the different phosphorus binders. Like we've tried all the different things. Like, let's not forget about these two other pieces if, that's an option.
Yeah, right. Super
The
fascinating.
other
So yeah, keep going.
I was gonna switch to another topic with phosphorus, so if you want to continue on that.
No, I was just saying, so what I'm hearing is that the better the phosphorus in range, the better it's a dictator of preserved renal function. So we really want to make sure we maximize phosphorus and get that lab level right because we're going, especially if someone's waiting for a transplant or something like that, we really want to preserve that as long as possible. I heard all of that. Was that right?
Yeah, and yeah, conversely, like high phosphorus levels, they definitely tend to um, increase the rate of CKD progression for sure. And so, I mean, that's where like earlier on we are looking at, let's eliminate phosphorus additives from the
Yeah.
diet and those kind of things. But the other really horrifyingly interesting thing that I found was a Cochrane review from 2018
Okay.
and it was looking at like sevelamer as a phosphorus binder as well as calcium-based binders, and they were
Mhm.
looking at outcomes. And what they found is that sevelamer may lower death for all causes compared to calcium-based binders and have less treatment-related hypercalcemia, but they found no clinically important benefits of any type of phosphorus binder on cardiovascular death, myocardial infarction, stroke, fracture, or coronary artery calcification.
Really?
Yeah.
So there is no point in taking a phosphate binder for those.
Well, initially that was my thought, and I was like, I am sickened by all the time I spent on all those phosphorus educations and
Mm.
all of the prior authorizations I did for all those phosphorus binders. But then I thought back to my earlier lesson about how there's so much more going on. And I kind of equate this back to albumin. Like, we know that high albumin levels cause poor outcomes for our CKD patients. Like,
Yeah.
that's just how it is. And so the there's always a lot of, dispute about how do we correct that to improve outcomes. And like when they had patients that were in the ICU, they would IV infuse albumin thinking to give them better outcomes, but it did not change anything. And
Mm.
that's because albumin, at least in part, is a screener marker showing there is a lot of shenanigans going on here. And I think to a degree, phosphorus is doing that because, again, it is controlled by hormones.
Mhm.
Um, it is telling us that there's some seriously bad stuff going on here, but correcting phosphorus levels alone is not going to improve outcomes. And I just think how complex things are because I mean, we're specifically looking at heart-related things here, so cardiovascular death, myocardial infarction, stroke, fracture, stroke, comma, fracture, um, or coronary artery calcification. And just like with calcification, we know there's such an important role with K2 for our CKD patients.
Yeah.
With cardiovascular death, we know there's so much importance of, potassium and anti-inflammatory diets. Or I also think about how common thiamine deficiency is, and
Mm,
that has so many similar symptoms to congestive heart failure. And I feel like that just gets overlooked a ton. So I just think that, cardiovascular death and all those complications aren't that simple, and we put a lot of burden on phosphorus control, and a lot of times that is narrowing our patients' diets and causing really poor quality of life for our patients because we're focusing on this one thing
yeah.
where, maybe, yes, we don't want them to have a phosphorus of 9, but maybe we need to just be looking at what's a dietary pattern that's gonna support cardiovascular health altogether and do what we can to support the phosphorus. Also thinking about the impact of phosphorus binders on gut health. There's a whole paper
Mm,
that
mm,
came out on that. And I
mm.
think that is part of it too, because your gut health plays such a significant role in all other aspects of your health. So I just think it's a really complicated thing. And I just love that the Cochrane review is saying, hey, just lowering phosphorus is not enough to improve these outcomes. We need to cast a wider net here.
Yeah. And I think that's the main message, isn't it? Everywhere is we can't get single nutrient focused.
Hmm.
That's why that's been our bugbear with potassium for so long. It's looking at treating someone as a whole, not as a mineral deficiency. Treat the cause, not the effect. Person, not the disease. And that's really our 101 when it comes to what K&I does, what we should be doing as renal dietitians, as naturopaths, and probably my thing of what I think patients are neglected when they're going through medical, unless they've got a really good integrative nephrologist or someone that's thought about this sort of stuff, is that we've got nothing but dialysis, and even making some dietary changes may or may not help, and we're here saying, well, actually there's a whole gamut of things you could do, but really you need a healthcare professional that knows what's what and can look at the whole picture and run. And that's again back to our integrative testing of why testing and not guessing is so important in these patients.
Yeah, I feel like we're such infants in our understanding that we need as much data as possible,
Yeah.
because when we have that data, like, it will help us ask better questions because we're like, oh, I wasn't expecting to see, this level be high and this other level be low. Like, I thought they would both be, it helps you ask better questions. And I think it goes back to, like, you just these minerals or these vitamins or these hormones, they don't work in isolation. And I think for too long the focus has been on, let's get these minerals into a good range because we know when they're too high, they cause all these complications. But we've done it at the expense of nourishing the patient. So I just think if someone is malnourished, not in the sense of like they don't have enough protein, which again is the main focus of malnutrition with kidney disease is protein malnutrition.
Yeah.
But if you don't have the vitamins, you don't have the minerals, nothing else is going to work right in the body. So you
No.
need to nourish the patient, give them enough vitamins and minerals. Don't be scared to give them vitamins, and
Yeah.
then see what sort of issues kind of fall away. And then what doesn't improve, then that's where you can see where the true dysfunctions are.
I think that is a really, really good point, and something hopefully, if anyone's a clinical practitioner and is listening, is taking that on board. And if you're a kidney disease patient, of making sure that you're looking or getting professionals to look in the greater broad net of connections and interconnections, and remembering that you're a whole human system and not just a couple of kidneys and a bit of
Right.
aldosterone going in there. Is there anything else you want to add to that? I mean, I'd love to get you back on and maybe we like deep dive into some really specific minerals and go right into their pathways. But as an overall, is there anything else or any other impressions that you were left with or want to pass on?
Uh, the other really big takeaway is that I got from doing this deep dive is that really assessing some of the minerals. Like sometimes it doesn't work out financially for people to get a big, huge, functional micronutrient test. But I think at minimum, more often checking those red blood cell magnesium levels for
Mm,
what it's worth, put in the context of the data you have, but also zinc, because
mm.
those with CKD, they can start losing zinc through their urine as early as stage 3,
Wow.
and especially where there's so much more of a movement for the lower protein plant-based diet, which I feel like does so many great things, but zinc in those diets is like in those plant-based diets is just not very well absorbed. And so I just feel like there's going to be a big gap there, and that's something that I do frequently see in my patients who aren't very diligent about taking their zinc supplement. They start to see hair loss and diarrhea and fatigue, and those things kind of together. I look for that trifecta in my patients. I'm like, you haven't been taking that zinc, have you? And they're like, oh yeah, I forgot about that. But I think that, again, because it's a new thing, if we can test for that, it's going to help give a little bit more hard data so we can get better at assessing our patients for zinc deficiency. And again, because zinc, it's a pretty, I don't know, nosy nutrient. It's really got its hands in every little pot.
Yeah.
Um,
Zinc
and
and
so,
magnesium, they're the two that I'm
yeah,
like,
those
they're pretty
two.
much, they're involved in like everything, every biochemical process in the body. You pretty much are going to need zinc and magnesium. That's
Exactly.
somewhere in there.
I
Yeah.
agree, and that's why I was just like, I routinely just really wanna see that information on my patients.
Yeah.
Um, Again, so I'm not just guessing on it and then, thinking about repletion doses when those levels are low. They're going to be higher than the RDA, and that is how it should be, because the RDA is
Yeah.
that bare minimum for healthy people. So if someone has kidney disease and they're low, they're going to need more. And
Yeah.
again, testing, replenishing, testing again is going to help us tighten in on those protocols of what most people is going to work.
Yeah. Yeah. No, minerals are far, I think they're underrated in their ability to work so systemically with hormones and, all of those sort of things. So I think they're the ones that we shouldn't forget in our arsenal of things that we can use to help improve people's outcomes.
Mhm.
If anyone wants to get a hold of Lindsey and work with her to rebalance and get all your minerals sorted, I'll put the link below, but you can find her at kidneynutritionalinstitute.org, and then you can go down to team and you'll find the link to find Lindsey there. She works via telehealth and online, so no matter where you are in the world, you can do that. And I'm assuming if you're in the States, you might be able to get some of that back on insurance as well. Lindsey, thank you so much for joining us. Remember to hit like and subscribe. That way you'll get notified anytime we put up new content. If there is a mineral that you would like to pick Lindsey's brain about, put it in the comments below and I'll be sure to let Lindsey know and we will do a nice deep dive on it. And yeah, if you want to know more about what we do, head to www.kidneycoach.com and you'll find us on Facebook, Instagram, and all of those amazing places. Lindsey, thank you again for sharing your amazing brain with me. I am definitely going to line you up for another discussion on. We might go into. I think I'd like to do one on zinc actually, because we've not done one on zinc. We've done all the others, but zinc I think we should get into because it is one that we've yes. So
Yeah,
I'll chat to you offline.
it's a pretty
All
good
right,
one.
Lindsay, thank you for your brain and your contribution, and I look forward to seeing you next time. And to everyone listening, thanks for being part of our community. We appreciate you. Bye.